Welcome to the VEITH Symposium. We're back here in New York, and it's great to be back. We have people from all over the world talking about the latest and greatest therapies for treatment of peripheral arterial disease. The main focus we'll be discussing today is looking at the role of atherectomy, drug-eluting stents, and bioabsorbable stents for the treatment of claudication and peripheral arterial disease. So we'll start with Dr. Adams. George, what are you learning today, and what do you think is the latest and greatest news?
That's a great question, Jim. So atherectomy, again, is a topic of discussion. And it's interesting to see how atherectomy is evolving, right? Since shockwave lithotripsies hit the market, they're trying to find new innovative ways to use atherectomy and not just look at it treating directional, but maybe using it as an orthogonal effect, much like lithotripsy in terms of prepping the vessel. I think the other thing that's really come and it is more apparent with today's discussions is the importance of prepping the vessel in terms of biologic therapies that are hitting the market. So vessel prep, I think, is a whole host of things, right? So you got optimal balloon angioplasty, you got non-compliant balloons with the jade, you've got focal force balloons, which there's a whole host of them, atherectomy, intravascular lithotripsy. I think those would be the main ones that would cover prepping the vessel.
Dr. Hicks, do you think that this is all really going to be done in conjunction with drug therapy, or is it going to be standalone therapy?
Its benefits are really in conjunction with a drug-based therapy, and I think we sort of had a setback a couple of years ago with all the data that came out with Katsanos and that group. But that's really what it's all about, is you're prepping the vessel, you're sort of creating in-channels or a way for that drug to permeate the vessel wall, and then that's going to get you the longevity of the effect. So I don't think they're meant to be standalone therapies, and I think we've sort of been at fault a little bit as comparing their efficacy in a standalone fashion, but I think what they're really going to shine is with concomitant therapies.
I have to agree. I think we're really seeing that we're using the best of all the therapies to try and get optimal results. Giovanni, in Europe, what are you seeing coming forward as the new innovative therapy for treatment of peripheral arterial disease, and how have you seen it brought forward here at the VEITH meeting?
Well, during the last years, especially for non-stenting zone, or so-called non-stenting zone, we use a lot of lithoplasty first, especially in the groin or in the popliteal. That's an extremely good option in patients with the calcified lesions. So, and I agree completely with the other colleagues, we can prepare the vessel for drug-coated balloons. Another option in Europe is for very calcified lesions of the femoral popliteal artery is the drug-eluting stent. And we have now also the new eminent data, which are very impressive. And so personally, for very long lesion and for calcified lesion, I would prefer in the so-called stenting zone, I would prefer drug-eluting stents.
I think that's something we're all kind of changing and involving our thought and really seeing the advantage of the anti-myoproliferative type of therapy. Caitlin, when you look at this, though, we have really two different types of anti-myoproliferatives. One's more sidal and one's more static. Where do you think we're heading with that?
Yeah, I think that's also a place we have a lot of room to improve. A lot of the vascular data is really focused on paclitaxel, and I think we're sort of way behind. I mean, the coronary literature has looked at paclitaxel and moved on, and we're sort of stuck back there. So I think we're going to see a lot of benefit as we move and sort of see our wave in the future. And seeing some of the talks today coming out of Europe, there's really exciting technologies on the horizon, and I'm looking forward to seeing them come into availability here in the U.S.
I think I would agree with you. So especially with the Meta-Alliance data, these Limus drug-coated balloons that are hitting the market, as well as the bioresorbable scaffolds, as you mentioned, with light BTK. I think Limus is a cytostatic, not only cytostatic, but an anti-inflammatory as compared to the sidal agents with paclitaxel. So I think it's exciting times. So hopefully we'll have some answers, especially to below the knee, that we can actually go to from a biologic standpoint.
Brought up a great point, looking at going below the knee with the Limus and everything else. Going from the coronary literature, how are you extrapolating that to go below the knee and above the knee?
Great. So in terms of the size of the vessel, they're very similar. In terms of the pathology of the lesion, very different. So I think, Jim, you sort of set me up because you started with the discussion of atherectomy, prepping the vessel. I think in order to get similar results, as we've seen in the coronaries with Limus, right, that we need to adequately prep the vessel. Not to say you shouldn't prep the vessel in coronary lesions, but I think you really got to do your due diligence below the knee.
Giovanni, what are your thoughts for the different agents? You have access to a lot of different technology in Europe. what agents do you think are going to be the best for using for below the knee for calcific and non-calcific lesions?
Well, the only solution at date is PTA, but we know the problems connected with the PTA alone. Dissections, we have restenosis, recoiling. So we need other technologies for better results. And in my eyes, the atherectomy would play a huge role in this. But we need data about it. And I hope that during the next years we'll have more data for more evidence for this type of technology. And I would like to connect also the two therapy concepts, the vessel prep and the treatment of the vessel with the drug-coated balloons, whatever, paclitaxel or everolimus or something like this.
I think that's one thing that came out very loud and clear today is vessel prep is key. We really need to get down to a residual stenosis of less than 30% to really be effective with our drug-coated therapy, whichever one we're deciding to use. Now, one thing we're coming out, it was kind of revisiting from the old Absorb trial for the coronaries, is the use of a scaffolding that's absorbable that's still drug-eluting. George, what are your thoughts on that?
From Ramon Varco's data out of Australia, very promising. I think, though, in regards to Giovanni's comment in terms of needing data, one of the things that's most important, especially below the knee, is making sure that we do our due diligence in picking the right endpoints. Right? Because sometimes the clinical trial design is the fault and it's not the device. We aren't asking the right question. So we got to make sure we're asking the right questions so we can adequately test the device. And the reason I mention that, to date, we've had 3 drug-coated balloon trials that have failed, 1 drug-eluting stent trial that's failed, and now we've got the bioresorbable scaffold that's on the line. Hopefully it will turn out positive to give us some treatment to treat below the knee.
One thing, Dr. Lukestein gave a very nice talk today looking at the use of coronary stents going below the knee, but they're not bioabsorbable, and he's showing excellent results. Well, how does that fit in your algorithm when you're looking at what to use below the knee once everything becomes available? Dr. Hicks, what do you think?
Yeah, I mean, I'll admit, off-label, I do use coronary stents below the knee currently for really exophytic lesions or calcific lesions. We just don't have great technology below the knee, and coronary stents are the right size, and they're the Limus drug elution, which is what we like. I'm really excited about sort of the concept of using them. I think I'm more excited about the bioabsorbable concept because what makes me scared is the instant restenosis in those tibial vessels that then leads to an acute occlusion, and then you've basically taken out the patient's entire runoff. So I think the benefit of a bioabsorbable scaffold is that you can sort of have that scaffolding support early on, let the patient sort of gain some sort of remodeling around that, and then it sort of slowly fades away, and you're left with a native vessel that hopefully, if it does have recurrent disease, won't have such severe consequences if it does fail.
I think the concept of having an anti-inflammatory in there, since a lot of atherosclerotic process is inflammatory in nature, really is going to add a benefit as we look long-term outcomes. Giovanni, what's going on in Europe, and what do you think there?
Well, we are performing some studies with bioresorbable drug-eluting scaffolds, but I have to say that the lesions below the knees are sometimes very short. There are good indications for drug-eluting stents. We know from the other studies, Destiny's 2 study, that they work very, very well. But for long lesions, we don't have a good solution, including drug-eluting stents. You know the results of the Saval study, which were really disappointing. So for this indication, we need other technologies probably.
I think that's one thing we're certainly finding here at VEITH today is that there's a lot of stuff we're learning more and more about, and we're getting better indications of what we can do and what we shouldn't do. Let's change topics just for a quick second to finish up, talk about atherectomy. We've discussed how really every type of atherectomy was discussed in the sessions today, and we're seeing exceptional results. But in the real world, Dr. Hicks, you presented some data that kind of shows it may not be that good. So what are your thoughts, and how do we put what we're seeing in clinical trials versus the data you presented from Medicare and VQI?
Yeah, I think that's a great question. When we here at VEITH, it sounds like atherectomy is just fantastic, but there's a lot of different atherectomy options, and people are using it very intentionally. So, everyone sort of that is here is on the forefront of PAD treatment, and you're seeing sort of the right selection for the right patient. I think in the real world, that's not necessarily the case. People have limited armamentariums. There is a financial component driving that. Certainly in the Medicare data that I presented today, a large component of sort of the atherectomy failures can be attributed to just overuse practice patterns and not actually device failures. So I think there's a little bit of some reimbursement issues that go along there, trying to really be intentional in the way that we treat patients and sort of making a patient-by-patient decision, and then spreading that knowledge to sort of the greater community beyond just here, where the experts are, to make sure that everybody is treating the patients properly.
We certainly see there's two real main areas of activity. One is the outpatient lab, and some are more hospital-based or cath lab-based. How are you seeing that as you look at your atherectomy data, and what can we learn from that?
Yeah, we're seeing essentially, to put it bluntly, not great outcomes in the OBL space, but I don't think OBLs are bad inherently. I think they're a great option for patients. They get in, they get out, they're treated really quickly and effectively. They bypass a lot of the hospital red tape. But I think what it opens up is with any sort of financial incentive, you get sort of overuse or abuse of these procedures. So I'm excited about the SVS and the ACS accreditation of the OBLs. I think that's going to be huge for us to really sort of recognize the people who are doing really good work and hopefully weed out the few people that are maybe not doing as great work, so they're not sort of ruining it for the rest of us.
Dr. Adams, what are you're doing in the cath labs and OBLs for cardiology regarding PAD and atherectomy?
I would wholeheartedly agree. I think a personalized approach is the best manner. If used effectively, as we know, it's very efficacious. The second thing I'd like to remark on is when you look at it, you have to make sure you ask the right question. So long-term follow-up, long-term outcomes, in my opinion, atherectomy plus an adjunctive therapy such as some sort of drug-eluting stent, balloon, direct drug delivery, whatever it may be, is a long-term outcome. Technical success initially is what you're looking at with atherectomy, with, say, plain old balloon angioplasty. So I don't think that long-term outcomes should be solely based on atherectomy. In terms of what we're seeing, I agree wholeheartedly. If you put a financial incentive to something, sometimes in a small group of people, hopefully, that they do it for the wrong reasons. So I think with accreditation, with more guidelines around this, it'll tighten the belt and hopefully provide the best outcomes to our patients.
I think that's well said, and I think we all want good quality data. Giovanni, in Europe, what are you seeing for how people are using atherectomy? Is there a financial component to it, or are you pretty much able to do what you want to do?
Oh, absolutely. In Europe, we have another type of reimbursement. This has obviously an impact how we treat our patients. Otherwise, we lose money. But I think that if we can provide data that some techniques work and we can save money for this, well, the reimbursement will be easy.
So I want to kind of close now as we discuss the different ways to use atherectomy. And I know as presented today, each device isn't perfect for every lesion. So give me your go-to devices that you like to use for highly calcific lesions, long lesions, focal intimal hyperplastic lesions, and combination thrombus and atherosclerotic disease. I'll start with George. We'll just come right.
I'd like to say that I think you, as an operator, you don't need to be versed in every atherectomy device. But just like you said, being able to treat from a homogeneous plaque to a calcific plaque to a restenotic plaque, if you can use two devices and you're competent at it, it's more than efficacious. So for me, I use two devices mainly. I use laser atherectomy. I'll use it for homogeneous lesion, heterogeneous lesions, and of course it's the only atherectomy device for in-stent restenosis. Most recently, the power laser is very efficacious in calcium, probably because it is the wire's off-centered from the fibers and you have a deflecting tip, so no dead space. That's above the knee, okay? Below the knee, for thrombus, heterogeneous plaque, I think the laser is very efficacious. For calcified plaque, orbital atherectomy for me.
Yeah, I have orbital atherectomy, I think, for below the knee, which is a lot of what I'm treating. In Baltimore, we see a lot of people with diabetes. Laser atherectomy, definitely for in-stent restenosis. And I do use directional atherectomy for sure. I don't find that to be terribly effective in calcified vessels, though. So I would say I'm moving more to intravascular lithotripsy in those patients.
I start with angiography, then PTA, look for the result of the PTA, and then I make the decision what I should do next. So it would be atherectomy. In case of relatively short lesion, I would go for DCB. For very calcified lesions and very long lesions, I will go for drug-eluting stents above the knee. For eccentric lesions, I would do directional atherectomy and DCB. And for long calcified below the knee lesions, after the PTA, probably vessel prep and DCB also.
For me personally, I tend to look and say, if I've got a eccentric plaque, I'll use directional atherectomy. If I've got a plaque at a joint space, whether common femoral or popliteal and a non-surgical candidate, I'll use directional atherectomy. If I think there's a combination of thrombus below the knee, I'll tend to use laser. If highly calcific, short lesions, I tend to use the CSI. Above the knee, if my wire easily passes, I'll use rotational with a jet stream to try and debulk the clot first. Then I'll come in and I'll do atherectomy beyond that. My whole goal, though, is I try and get less than a 30% residual stenosis. Then I'll use adjunctive therapy on top of that. So I think this kind of summarizes a lot of the exciting things we're seeing here at VEITH, and it's amazing the amount of people coming in with new information, new thought process, and now we're all back together and we can exchange these stories both within the lecture hall, but more importantly out here as we mingle among each other and really talk about what's happening on not only in the U.S. but across the world. So hope we can see you next year at VEITH, and have a good day.